You know, if you break your arm, an X-ray gives you this really clean, jagged white line.
Right. It's totally obvious.
Exactly. The doctor just points to the glowing screen, and it's entirely binary.
Yeah.
It's either broken or not broken.
Yeah, which is very reassuring.
It is, because we inherently like things to be visible and, neatly categorized. But the moment you step into the world of women's reproductive health and neurodevelopment, really, that X-ray machine is just, well, it's completely useless.
Oh, absolutely. The clinical reality of diagnosing hormonal conditions is just, it's almost entirely devoid of jagged white lines.
You're instantly looking at a diagnostic landscape that is incredibly murky, which is why, welcome to this custom-tailored deep dive into your sources. Today, we are wading directly into those murky waters.
We really are.
We're going to unpack a condition historically surrounded by confusion, stigma, and frankly, some terrible statistics. Premature Ovarian Insufficiency, or POI.
Yeah, and the urgency of this topic, it becomes so clear the second you look at the updated global estimates and the sources you provided.
Right, because for decades, the accepted medical consensus was that POI was this really rare anomaly. They thought it affected maybe 1 in 100 women.
Which is just wildly inaccurate now. The latest global data corrects that significantly. It shows the prevalence is actually hovering between 3.5 and 4%.
Wait, so 4 in every 100 women?
Yeah, under the age of 40.
Wow.
That shift from 1% to 4% fundamentally changes how we need to view population health. That moves POI from a fringe medical curiosity to a highly prevalent condition that you or, someone close to you is statistically very likely navigating right now.
That's huge.
Yeah.
So our mission for this deep dive is to completely unpack what POI actually is, understand the biological mechanisms behind why it happens, and clarify exactly how it is diagnosed in women under 40.
And what's fascinating here is that the word ovarian in the name often misleads people.
Oh, into thinking it's just about fertility.
Exactly. But when the ovaries stop functioning properly, it triggers a systemic health shift. Estrogen receptors are distributed throughout the entire body. So a drastic drop in estrogen impacts bone density, cardiovascular health, your neurological function, and even psychological well-being.
So it's everything, which means whether you are advocating for your own health, a partner's health, or you're just curious about human biology, understanding POI is really a masterclass in how interconnected the body is.
It absolutely is.
But I guess before we can even look at how doctors attempt to diagnose this, we first have to establish exactly what the condition is, and maybe more importantly, what it isn't.
Yeah, the terminology has always been a bit of a minefield.
Right, so the guidelines define premature ovarian insufficiency strictly as the loss of ovarian activity before the age of 40.
The timeline is the defining clinical marker here.
Because the ovaries stop functioning normally, right?
Yeah, right.
Like they stop releasing mature eggs and start producing crucial sex hormones like estrogen, progesterone, and testosterone.
Exactly. And the age cutoff is key. The average biological age for natural menopause sits between 45 and 55. If a loss of ovarian function happens between 40 and 44, the medical community classifies it as early menopause. The specific diagnosis of POI is reserved exclusively for patients under 40.
Okay, let's unpack this terminology a bit more. Because the sources spend a significant amount of time addressing the older names for this condition.
Oh, right, back in 1942.
Yeah, Fuller Albright. This Harvard endocrinologist observed young women presenting with absent periods, and he officially coined the term premature ovarian failure, or POF.
And for over half a century, that was the standard label.
But the current guidelines explicitly warn against using the word failure today.
Right, because the shift from failure to insufficiency is rooted purely in scientific accuracy. In 1942, they just assumed the ovaries had died.
Like they just permanently shut off.
Yeah, that all follicle activity had permanently ceased. But we now know that POI exists on a continuum. It's inherently characterized by a fluctuating nature.
So they might sit dormant for months and then just spontaneously wake up.
Exactly. A woman might not have a period for 6 months and then suddenly experience a totally normal menstrual cycle as her hormone levels temporarily bounce back.
I was thinking about it like a factory. Calling it a failure implies that the ovarian factory has permanently burned to the ground,
Right, the doors are locked.
Yeah, the machinery's destroyed, the operation is just over. But insufficiency means the factory workers are just taking these unannounced, unpredictable breaks.
That's a great analogy.
The machinery is still physically there, and occasionally someone flips the switch and it runs for a day, but it simply isn't operating with any consistency.
Yeah, and that fluctuating reality makes failure medically inaccurate. And honestly, it's unnecessarily devastating for patients to hear. Telling a 25-year-old woman that her organs have failed carries a massive emotional weight.
It sounds so final.
It implies a permanent finality that just doesn't align with the biology. Insufficiency leaves room for the biological truth that there is still some underlying, albeit erratic, function.
Okay, but if the factory is taking these unpredictable breaks, the immediate question becomes, why? What triggers the ovaries to stall out so early in life?
Well, the sources categorize the known causes into a few distinct buckets. First, you have your iatrogenic causes.
Which essentially means medically induced, right?
Yeah.
Like chemotherapy or pelvic radiation for cancer treatment, or maybe surgical removal of the ovaries.
Exactly, like a bilateral salpingo-oophorectomy. And the mechanism there is straightforward but severe. Chemotherapy drugs are designed to target rapidly dividing cells, right? That's how they eradicate tumors.
But the ovaries are super active.
Right, they're constantly cycling and developing follicles, so they essentially get caught in the toxic crossfire. The radiation or the chemicals damage that finite reserve of eggs, burning out the supply decades early.
Which is why the guidelines say doctors have to talk about POI before starting cancer treatments.
Yes, it must be a central part of the informed consent process.
But beyond medical interventions, the sources also point to genetic factors, things like Turner syndrome or carrying the fragile the FMR1 premutation.
Yeah, chromosomal abnormalities play a massive role. With Turner syndrome, a female is born with one missing or partially missing X chromosome. That directly disrupts normal ovarian development right from birth.
And Fragile X is different, right?
Yeah, the Fragile X premutation involves a genetic stutter on the X chromosome that leads to a toxic buildup of RNA within the cells, which over time damages the ovarian reserve.
Okay, so we have iatrogenic, we have genetic, and then there are autoimmune causes, which is wild to me. The concept of the body's immune system attacking its own reproductive organs just seems really counterintuitive.
It does, right. We usually associate autoimmune diseases with joints or the digestive system.
Right.
But here, the immune system essentially loses its self-tolerance and produces antibodies that specifically target steroid-producing cells, which includes the developing eggs.
Oh,
Yeah, and this condition rarely happens in isolation. A woman with autoimmune POI is statistically much more likely to have other autoimmune endocrine issues, like autoimmune thyroiditis or Addison's disease.
okay, but here's the thing. Even with all those defined mechanisms, the chemo, the missing chromosomes, the antibodies, the sources label 70 to 90% of non-iatrogenic cases as idiopathic.
Yeah, that's a huge number.
I mean, isn't idiopathic just a fancy medical term for we have absolutely no idea?
If we connect this to the bigger picture, yes, it's just a clinical placeholder for the limitations of current medical science. It's highly likely they aren't random at all.
So what's actually happening then?
Well, many of these women likely have complex polygenic interactions. It's not one single broken gene, but a cascade of subtle genetic variations that, combined with unknown environmental factors, just drain the ovarian reserve faster than normal.
We just can't see it yet.
Exactly. Our diagnostic microscopes simply aren't powerful enough to detect those subtle polygenic cascades yet. It's a massive frontier in women's health research.
Living with that kind of day-to-day unpredictability, especially when the root cause is invisible 90% of the time, must make getting a diagnosis incredibly difficult.
It's notoriously tricky.
Because if the trigger is a mystery, doctors and patients have to rely heavily on the physical warning signs the body sends when that estrogen supply drops.
And let me tell you, estrogen withdrawal is a profound systemic shock to a young body.
Yeah, the texts point to allego, amenorrhea, so infrequent or absent periods as the primary red flag. That's what usually brings women to the doctor.
Right, but the symptoms go way beyond periods. Up to 80% of women with POI experience classic vasomotor symptoms, like hot flushes and night sweats.
Which is just wild for someone in their 20s. Why does that happen?
Well, estrogen plays a vital role in regulating the hypothalamus, which acts as the body's internal thermostat. When estrogen plummets, the hypothalamus gets confused. It misreads the body's temperature as being dangerously hot.
Oh, so it overreacts.
Exactly. It triggers a massive cooling response. It dilates blood vessels to release heat and causes profuse sweating. That's the mechanical reality behind a hot flush.
And along with those, there are genitourinary symptoms, like vaginal dryness and pain during sex. But here's where it gets really interesting. Looking at the patient-reported symptom charts in the guidelines, There's some deeply surprising systemic effects.
Yes, absolutely.
Like 5 out of 10 women with POI report chronic dry eyes and joint clicking,
Yeah.
and 3 out of 10 report tingling in their limbs or sudden bouts of vertigo. I mean, if a 30-year-old is dealing with joint clicking and dry eyes, she's probably at the optometrist and the orthopedist, right? She has no idea her ovaries are at the root of the issue.
She wouldn't because we aren't taught to connect those dots. But estrogen is absolutely crucial for maintaining mucosal hydration across the entire body, which mechanically explains the dried eyes and vaginal dryness.
That makes so much sense.
And it regulates fluid and reduces inflammation in the synovial joints, hence the clicking and stiffness. Furthermore, estrogen interacts very closely with the central nervous system.
Really? How so?
Well, there is a high concentration of estrogen receptors in the hippocampus, which is the brain's memory center. So when you starve those receptors, you see the vertigo, the tingling, and the severe brain fog and mood swings that 7 out of 10 women report.
So they aren't random ailments. They're direct consequences of an estrogen-starved system.
Exactly. And because of the fluctuating nature of POI we talked about, those symptoms aren't even a constant baseline.
Oh, right. Because the ovaries might randomly sputter back to life.
Yes. Pumping out a surge of estrogen for a month, suddenly the joint pain vanishes, the brain fog lifts, and the patient thinks they're totally cured.
But then a few weeks later,
The estrogen crashes again, and the symptoms return with a vengeance. It creates this profound emotional whiplash. The patient feels like they cannot trust their own body.
that sounds incredibly isolating.
It leads to severe psychological distress, which is exactly why the guidelines mandate that doctors signpost patients to support groups like the DAISY network. Treating POI requires far more than just balancing hormones on a chart.
And I imagine that unpredictability is what makes diagnosing it so rigid. Like, a doctor can't diagnose a lifelong condition based on symptoms that might vanish next Tuesday.
Exactly. We need definitive biochemical proof, but getting that proof is highly specific.
So what are the actual rules for diagnosis then?
The clinical gold standard requires a few things. First, the woman must be under 40. Second, she needs a documented history of disordered menstrual cycles for a minimum of 4 months.
4 months. Waiting 4 months seems agonizing if you're dealing with daily vertigo and night sweats.
It is a really difficult waiting period, but it's biologically necessary. Acute physical stress, rapid weight loss, or even a severe transient viral infection can temporarily suppress the hypothalamus and pause your cycle. Giving it 4 months ensures the cessation is persistent.
Okay, but cycle history alone isn't enough, right?
Yeah.
The definitive proof lies in measuring FSH, follicle-stimulating hormone.
Yes.
I was actually looking at how FSH works, and my favorite way to visualize it is the thermostat and the furnace. The pituitary gland in the brain is the thermostat, and the ovaries are the furnace.
I like that.
So the brain produces FSH, which is basically a signal shouting at the ovaries to grow follicles and make estrogen.
Right, and when the ovarian furnace is working, it pumps out estrogen. The brain senses that, realizes the room is warm enough, and lowers the amount of FSH it's producing. It's a perfect negative feedback loop.
But with POI, the ovaries are insufficient. They aren't making estrogen. So the brain checks the blood, realizes the room is freezing cold, and just decides to shout louder.
It pumps out more and more FSH, desperately trying to force the ovarian furnace to turn on, which is why a high FSH level is the definitive marker that the ovaries are failing to respond.
So what's the actual number they look for?
To confirm POI, the FSH concentration must be greater than 25 international units per liter. And crucially, because of the condition's fluctuating nature, a single test is never enough.
Oh, because it could just be a random spike.
Exactly. The FSH must be elevated to that degree on 2 separate blood tests, taken 4 to 6 weeks apart.
But reading through those testing criteria, there is a massive blind spot that patients really need to be aware of. The sources explicitly state that hormonal contraceptives can entirely mask POI.
Yes, this is a huge issue in clinical practice.
Like, testing a woman's natural FSH levels while she is actively taking the birth control pill is like trying to measure a room's natural baseline temperature while a massive air conditioning unit is blasting at full speed.
That's spot on.
You aren't measuring the room's natural state. You are only measuring the artificial environment created by the AC.
Biochemically, the pill feeds the body synthetic estrogen and progestin. The brain senses those synthetic hormones, assumes the furnace is working perfectly, and completely stops producing FSH.
So her FSH levels look artificially normal.
Yes, even if her ovaries are completely dormant underneath. So to get an accurate reading, you have to turn off the AC. You have to stop the synthetic hormones entirely.
Otherwise, a woman could mask her POI for years. She might only find out when she wants to get pregnant, stops the pill, and her cycle just never comes back.
Which happens frequently,
Yeah.
unfortunately. And the guidelines outline other testing protocols doctors should avoid too. Like, they warn against routinely using AMH anti-Mullerian hormone as the main diagnostic test.
Which is super confusing, right? Because if you step into any fertility clinic, AMH is touted as the ultimate test for your ovarian reserve.
It is, because AMH is produced by the small early stage follicles. It tells us the size of the reserve, which helps predict IVF responses. But it doesn't tell us about the current function of the factory.
Oh, so you can have low AMH but still be ovulating.
Exactly. Plus, AMH testing varies wildly between different commercial labs. FSH remains the definitive standardized marker.
Now, there's one major exception to this entire testing maze. The 4-month wait, the repeated FSH draws, and that's surgical.
Right.
If a woman has both ovaries surgically removed before 40, she gets an instant diagnosis of POI. The biological source is gone, so biochemical confirmation is just unnecessary.
The physical reality supersedes the testing protocol there, yeah.
So what does this all mean? We started by looking at a diagnostic landscape that felt entirely muddy. But through the clinical guidelines, the structural reality of POI actually becomes very clear.
It really does.
It's the loss of ovarian function before 40, affecting up to 4% of women. It's diagnosed through a strict combination of absent periods for 4+ months and 2 high FSH tests taken weeks apart.
And it requires everyone to recognize that estrogen withdrawal causes profound full-body symptoms.
Yeah. So whether you are experiencing unusual systemic symptoms in your 20s or 30s that keep getting brushed off, or someone navigating this, understanding these diagnostic criteria is the ultimate tool for self-advocacy.
Because we exist in a system that often dismisses young women's hormonal complaints as just stress. Knowing the strict rules of the diagnosis gives you the vocabulary to demand the correct tests. And I want to leave you with a final lingering thought from the sources that completely subverts how we traditionally view this. Because POI is an insufficiency with fluctuating activity, women with this diagnosis still have a 5 to 10% chance of natural, spontaneous conception.
Wait, really? Even after all that rigorous testing and confirming the loss of normal function, 1 in 10 women might still naturally get pregnant.
Yes. It presents an incredible biological paradox. If a system literally defined as insufficient, a factory that can't even maintain baseline estrogen, still retains a 1 in 10 chance of spontaneously creating new life. I mean, what does that say about the sheer stubborn resilience of the human body?
That's incredible.
It suggests our understanding of biological finality is far from complete. Even when the diagnostic X-ray looks completely broken, the body is often quietly finding a way to work in the dark.
You think you're looking at a clean binary end to a process? But human biology continuously refuses to be that simple.